Over to Dr. Meena for management of strabismus after congenital cataract surgery, which is not uncommonly we face strabismus after congenital cataract surgery, whether unilateral or bilateral, due to asymmetric refractive errors, as already shown by Dr. Satish, that it can be unpredictable. Over to Dr. Meena.
Good afternoon, everyone. At the outset, I would like to thank Laila Madam and KSOS for this opportunity. I'll be speaking on management of strabismus following congenital cataract surgery. About the incidence of strabismus following congenital cataract surgery, the range is a very wide range. Like the study shows that the rate of strabismus is almost ranging from 20.5 to 86%. So that itself shows that it's not a very rare thing following congenital cataract surgery. Obviously, there is an association between congenital cataract surgery, you have an aphakic period, you can go for amblyopia, and this itself can cause a sensory type of strabismus. So all these are associated. So this is one problem. That is the main reason for strabismus to occur. It's mainly a sensory form of strabismus. So coming to the mechanism, as I mentioned earlier, it's mostly a sensory type of strabismus, and laterality matters. That is, unilateral cataracts have got a greater tendency to develop strabismus. And also when you put the IOL, if you put a primary IOL, it will be better. Like secondary IOL, you have a period of aphakia where your correction may not be correct, and proper follow-up and refractive correction post-op. That is the most important thing, because the child's eye is growing, the refractive status keeps on changing. So maybe your power you give may be quite different after 3 or 4 months. So that itself matters, and definitely amblyopia. Now, what are the types of strabismus that you can get? Any committance, just like the committant strabismus, you can get any forms, but the usual ones that we encounter are the horizontal ones, the exotropias and the esotropias, and also the dissociated deviations are also not rare, like the dissociated vertical and the dissociated horizontal deviation. And it's not that you don't get vertical one, but these are the common ones. Now, what does the literature say? Like the literature say that about approximately 10% of patients will undergo strabismus surgery within 5 years of pediatric cataract surgery, which may not be true in all scenarios, and younger age, female sex. So there are so many studies which give quite variable results. So that itself shows that there is no particular guideline for the treatment of strabismus following cataract surgery. And here it shows that the motor results were better than the sensorial results, definitely, especially when you have unilateral cataracts. And also, you have to be very careful when doing strabismus surgery in these patients, because results may not be predictable like you do it in a usual common committant strabismus. We had done a short study in our institute where it was to compare the biometric status of primary and secondary IOLs, and here we found the squint was assessed as a secondary variable, and we found that primary IOL was associated with very less tendency of developing strabismus compared to the secondary IOL. Maybe due to that period of aphakia, and we found exotropia was more common than esotropia. Now, coming to the management strategies, that is the most difficult part here. The when to manage is not how to manage. It's mainly when to manage and when to intervene. And usually your idea will be to treat a constant strabismus with a fair vision. So since we don't have any particular guidelines, we'll go into some of the scenarios here. Like here, this girl was operated both eyes for congenital cataract with IOL at between 1.5 and 2 years of age. And her current age is 6.5, nearing 7 years. And this is her refractive status now. Like she has come to almost bilaterally 6/18 vision, and there is no unilateral amblyopia or anything. And she has developed an esotropia of 30 to 35 prisms. So in such cases, like when you have there is a potential for binocularity, you can go for a little early, not that early, but little early surgery. And here I would go for a bilateral MR recession in this child. So here there is no unilateral amblyopia. So there is definitely, the child has reached only 6/18, but there is still potential for development of binocularity. So here I would prefer a bilateral MR recession. Now coming to this case, which was an asymmetrical lamellar cataract. He came at 4 years of age and he had dense cataract in the left eye with very poor vision, and we had operated in the left eye for lens aspiration, primary posterior capsulotomy and an IOL at 4 years of age. The right eye also had lamellar cataract, but the center was clear and his vision was 6/6 in the right eye, here you can see. So he is under follow-up, but he had lost to follow-up and he had come with a small exotropia initially itself. So at 11 years of age, this is his vision status, like 6/6 parts in the right eye, and it's only counting finger 1 meter in the left eye. And this is a dense amblyopia. In such cases, I would prefer to go for a single eye surgery, that is a resect procedure. Here it would be advisable to do. It's not that you can't do bilateral surgery, but no parent will like us operating on a sound eye, and we also will be comfortable operating on a dense amblyopic eye. So it would be preferable to do a resect surgery in this case, and that too you can wait, because whenever the cosmesis is most needed in these children, it would be the ideal age to operate. If you operate at a very young age, they can come with recurrence or overcorrection, so you have to be very careful when operating on such children. This girl again operated at 4 months of age. She underwent lens aspiration, PPC with anterior vitrectomy at 4 months, both eyes, and secondary IOL was done at 1.5 years in the right eye, and in the left eye it was done close to 2 years. So there was a gap between secondary IOL insertion in both eyes, mainly because we didn't get an anesthesia fitness because of various systemic issues for the child. And here you can see that she suddenly developed a esotropia in the left eye, and it was very difficult. Though we put an IOL later, she's still on amblyopia therapy, and here again we would prefer a resect procedure. And the vision is improving, but still in that small gap she developed so much of amblyopia in the left eye. So aphakia and pseudophakia one eye and aphakia one eye, it's a very difficult situation to correct or treat. So these are cases of constant strabismus, but there are conditions like variable strabismus, like here you can see there is associated nystagmus, the siblings, they are developing intermittent esotropias also, and the squint is not stable. So there are many strabismus following congenital cataract surgery which are not stable, that you can get variable esotropias, exotropias, etc. In such cases, it would be ideal to wait because you don't have a proper measurement of the strabismus. So it would be ideal to wait and operate at a later age. So be in no hurry. This is an example, like you are quite justified to do a surgery in this child, a large angle esotropia following cataract surgery, and I operated at about 2 years, I think, and later the child comes like this. So you feel bad like when they come with so much of overcorrection, and though a second stage we can do, maybe it's not your mistake, but still you have to be very careful when operating on conditions of strabismus where you have associations of congenital or any form of cataract. So the second sentence explains that mistake, or for being in a hurry, like you can have a delayed emergence of exotropia with longer follow-up, which indicates a need of caution in managing early esotropias in these children. This is from the infant aphakia treatment study. So be careful when you manage the strabismus associated with congenital cataract. Be in no hurry, and it would be ideal to operate on constant, and be very careful when you go for variable squints. Thank you all.
Thank you, madam, for discussing those interesting cases with strabismus and cataract and how to and when to